Okay, so welcome to the introduction on the central nervous system. So this is a picture of what brain development looks like in utero. We start over here on the left side of the screen, and there is just these cells are made up in a linear fashion. There is a rostral end and a posterior or a caudal end, the posterior end, caudal. Rostral and caudal, you'll see from time to time as you're reading. Um, so it kind of lines up with anterior and posterior. Caudal, you'll see a lot more. The caudal end of things would be like a lower end, the backside of something, a caudal end. Anyway, so we start up with these cells. It's a neural tube, and the way they are is actually, let me grab a piece of paper. So if this I just need one flat piece of paper to demonstrate this. Okay, so you start with cells and they're flat like this, and then they fold over like this, and they become the neural tube. And they actually start to seam from the anterior or rostral end all the way down to the caudal end. So it does make a zipper-like seam like this, and it's from rostral to caudal. The reason that becomes important later is that sometimes this it won't completely seal at the bottom, and then that's when you get some of the meninges can extend out of the body, but we'll look at that later. So we start with that kind of situation here, that neural tube. So we get the neural tube, and then this differentiates into the different parts of the brain. So these are called the primary brain vesicles, and they become your forebrain, midbrain, and hindbrain. So we have the telencephalon, the diencephalon, and then the mesencephalon, the metencephalon, and the myencephalon, which you don't really hear about. We'll focus at the beginning on these two. But the telencephalon is what's going to become what you think of as your normal brain matter when you picture the brain. The diencephalon folds in deeper, so it's an interior area, and then the mesencephalon becomes the three parts of the mesencephalon is one of the three parts of the brain stem. And then most distally, you have the spinal cord. So, so we'll see how this folds over. Along with all the actual physical matter of cells, you also have ventricles and an aqueduct, and then a canal. So all of these are hollow regions. So the ventricles and the canal are where the cerebral spinal fluid is circulating. So in development, there starts to become a folding over, and this is because we have the bone matter developing and constraining this area so that it has to fold into itself in order to have a place to exist within the constraint of the cranium. So it folds over, and as the brain matter develops, this is the part that's going to become more of the cerebral hemisphere, right? And you can see how the diencephalon in purple got tucked in and under, and then the rest of the brainstem here stays as a tail, if you will, from where the cerebrum is, because the cerebral hemisphere is what's going to grow the most as far as physical cell matter goes, and it continues to fold over and over again, which is why we get these fissures and sulci, this kind of folding over look. So we've said it, or I've said it once or twice already, but just to see it again, in the adult brain, we have the cerebrum. We have the diencephalon. The cerebellum is this cauliflower-like, I don't know why I call it that, but this is more a fluffy kind of looking space, the cerebellum. The brain stem, right, is all in green here. And again, it's broken down into the midbrain, the pons, and the medulla oblongata. And the last thing I want to say about this is, oh, guys, sometimes the slideshow gets ahead of me. I don't know. I create this as a whole new PowerPoint and everything, but yeah. So this is anyway. So this is what the adult brain looks like when it's fully developed, and we'll talk about each part and what they do, and as we go through everything. I mentioned the ventricles, so here's a lovely image of them, right? So again, this is a hollow space for the cerebral spinal fluid to circulate. It's going to circulate within the brain, go all the way down the entire length of the spine and back up again, but it all stays within the central nervous system. It doesn't come out. If it were to come out, then we have an issue. So we want it to stay within that system. The ventricles are labeled first, second, third, fourth, or sorry, there's laterals and then the second, third, 1, 2, 3, and 4. There's a canal, as was mentioned, and then the aqueduct is simply this little space that the connects the ventricles, the lateral ones, to the third and fourth part. Fissures. So fissures here are these more deep inset grooves. So this is the longitudinal fissure, and they are rather deep. And again, they're a result of the enfolding of the brain. This is considered the cerebral cortex, and that just simply means the most outer layer. So what we're looking at is the cortex. Okay, it's divided into the left side and the right side. What's interesting, if you look at this, it's not in our typical anatomical position, right? So because we would have already considered that the right hemisphere. So this is not an anatomical position. This is, and it's also a view from the transverse plane. Just to name some things here, we have the frontal lobe, the parietal lobe, really easy, right? Because that labels right up with how the bones are. Frontal lobe, parietal lobe, and occipital lobe as well. So veins and arteries are here. They're covered by the arachnoid matter, and we'll look at the 3 layers coming up soon. Here is a sagittal view, just to name the lobes again, which you can see. Again, we have this transverse cerebral fissure, so it's moving across that space. We can see the cerebellum again. We get the temporal lobe in this view that we didn't see before. Otherwise, it matches up again nicely with the way we name the bones. One could argue, well, the parietal bone is here, and it's not this space, but more or less, it's mirroring what we looked at with the cranium. So here's the cartoon picture of it. And then you see a slice taken away, and it shows you the deep fissure of that deeper inset of a fold. When it doesn't go as deep, it's considered a sulcus. And then the gyrus is just a bump. So it's that this has a wavy kind of bumps to it. Each region of the brain is associated with very specific function and movement. So as we look at this, I'll go through some of the traditional specifications that are fact about how or when our brain is activated based on what we're doing, thinking, etc. That all lines up. But this is one of the most unexplored or not quite understood areas. We can treat things really well. We can do a lot with the brain already at this point as far as medical intervention goes, but there's still a lot of mystery around it. And so you'll hear me when I start to say, like, well, this part of the brain controls that. There's always a caveat, like, well, unless there's a situation or you remap in a certain way. But for the most part, just we'll look at it as a general overview to be as true as we want to make it. So the cerebral cortex is considered the executive suite. So this is our perception, voluntary motor initiation, communication, understanding. The gray matter is composed of neuron cell bodies, dendrites, glial cells, and blood vessels, but has no axons. It's 40% of the mass of the brain. Here's a little image of how when I'm looking at something, that area of the brain gets highlighted, and that's where the interpretation comes from. When I'm talking, it happens here, hearing here, and then thinking has a more spread out kind of illumination. What's interesting, if you think about this, this is the anterior part of the skull. This is the occipital lobe. This is frontal lobe. If your eyeballs are here, but then they shoot information all the way back to the occipital lobe, and there's actually neural connection on a physical structural level that makes sense that this is where the interpretation goes. So the sum of it anatomically makes sense, like with the eyes. So this is a lovely map about which section controls which part. So if we divide everything here at the central sulcus, we do have a predominantly motor area, so action movement that we do and control voluntary movement, let's speak of first. And then here in sensory, this is areas that are going to have sensory reception. So if you think of hearing and sight, right, as a sensation, then this makes sense, right? There's a sensation coming in. The information is synthesized here in the occipital lobe, and then if you remember where the hearing was, it was about this this portion, which is part of that kind of posterior side of the brain. If you were to read through each of these, so each gyrus has a different name here. The primary motor cortex is the first one from the central sulcus. The second one is the premotor cortex, right? And then it gets into more specific naming, and the sulci, it gets a little more I want to say like interluded, interwoven. There's a little more action in the pattern here, but nonetheless, specific places have different areas. So, so this one's named Broca's area, and this one is Wernicke's area. Those often get talked about because they have to do with aphasia. So aphasia is the inability to speak, but phenomena is that if I can't speak because I know what I want to say, but I can't get my mind to make my mouth, my tongue, my vocal cords to say it, then there's a lesion in the Broca's area. If I if I know what I want to say, but then I I can't get the words out because I can't construct the sentence based on what I'm thinking, then it's a problem in this sensory area, in the Wernicke's area. So each of them lead to the same outcome, which is that the person is unable to express themselves, but it's for different reasons within the brain. Okay, so and then if you see there's little bits and pieces. The cerebellum isn't labeled here, but I do love to talk about it because this is a heavy motor area for action and movement, but so is the cerebellum is responsible for non-conscious motor control. So I just want to point that out now. Okay, it gets even more fun. So this is called a homunculus, and this is really cool because if we take a look at the brain, now this one's upside down from that previous image, right? So this is the anterior frontal lobe, posterior occipital lobe would be back that way. So we take a cross section here, we slice it, and then we draw our homunculus in. And the way you read this, the red is motor, so we're anterior to where the slice happened at the central sulcus. The way you read it is that the foot here is small, has a small representation compared to, let's look at the big hand. Okay, so this region of the brain is going to be responsible for the movement of the foot. And then as you go up and you see the hand is represented as big because there's more neural control in the hand than there is the foot. It's the same thing with the face. There's even more neural control with the face, and so it's represented as larger. Less neural control is in the elbow and the wrist, so those are represented in a smaller way. The opposites, the other side here is going to be sensation or sensory input coming in, but the same concept applies. And it's a little bit different right here. We see that we have a wider spread with the leg, the hip, and the trunk. The and then the head is also represented in this area. We have the same mirror image of the hand and also the face having a lot of sensory input as well. So, or neural action, a lot of neural control, neural action, neural reception based on the amount of activity within the brain there. Okay, so so we've been talking about the cerebrum, and I mentioned gray matter and white matter. Um, so let's look at a cross section of the spinal cord. So um, basically, if the cell body is here and then it branches out into its axon, the axon is the white matter and the body is the gray matter. The reason the gray matter is darker in color is because of the nucleus. So if it's the cell body with the nucleus in it, it's going to show up darker than that paler white axon. It's mostly myelinated. There's some unmyelinated axons as well. So this is the difference between gray matter and white matter. And this is just a drawing. So if the neuron is here, so let's imagine one neuron, this is the cell body, and here's our dendrite, the axon. The axon is going to then run rostrally to caudally, so it's going to run up and down to communicate. So this is just a spinal cord section, right? So this is just a section of it. And let's say that this is the neck region, this is in the kind of the thoracic region here. You'd have information running up towards the brain and down and away towards the feet for sensory reception and motor output too. We'll just keep looking at it. So in the cerebrum, we also have that gray matter, white matter effect. So again, neural cell bodies, axons branching away. So all in those dark matter, that's all our neural cell bodies. So also very interesting, right? Every one of these little dark matters has its own name and a set of functions that it's associated with. So when you go into advanced studies in neurology, you'll map out even more than what we'll cover in this section. So here again, I think I'm just trying to illustrate neural synapsing. So if you have a neuron with its cell body branching out, it's going to synapse with an interneuron, and then that interneuron will synapse with another neuron into the peripheral nervous system and then activate something. So so this kind of happens within the central nervous system and then communicates out to the peripheral nervous system. The same thing would happen in the opposite direction. So if I had sensory input coming in, I would receive it, it would get transmitted, and then it would synapse with another neuron to go and ascend to the cerebrum for interpretation. So the right side of my brain maps the left side. So if I'm raising a glass of water with my left hand, my motor control is happening from the right side of my brain. And and likewise with the opposite side. So that's called contralateral association. So it's the opposite side of the brain that's associated with the body movement. If you were, we'll talk about stroke, if you were to have a cerebral hemorrhage or a ischemic attack of some sort, right, where there's an issue with blood in the brain that causes damage to the brain cells, then with your motor control, it's going to actually show up on the opposite side. Okay. So cerebral vascular accident, CVA, is what we call a stroke, cerebral vascular accident. So it makes sense because you have the cerebrum. It has something to do with vascularization. I mentioned hemorrhage, which would be excessive bleeding. Ischemia is lack of oxygen to that area. So again, that would be a vascularization problem because it's the blood system that provides the oxygen to the brain, right? And an accident is that we clearly didn't do it on purpose. The brain has yet to figure itself out. So yeah, we're still trying to figure out exactly how everything works, but we're not doing bad. Look at this cross section. This is why I call it the cauliflower. When you take a cross section of the cerebellum, it starts to kind of have that cauliflower look to it. And this is cross section here as well. Okay. We covered this for brain regions. This is review, but this isn't. Let me go back. So in that previous cross section, you could see the corpus callosum. This is this central interior part that really helps communicate both hemispheres of the brain. It's like the connecting bridge between the two. Olfactory bulb, that's the nervous tissue that's associated with right here, olfactory bulb with sensation of of smelling. So this is so cool because this actually is the one that will exit out. There's neural receptors on the outside of the epithelial tissue, right? So it's right there, and it picks up the chemicals that are sent, and then we get that information sent into the brain system that way. So it's really neat how close to the physical outside world that part of the brain is, or the nose in general. Okay. We also have here a little bit more detail on the visual cortex. So we have a primary visual cortex in this area within the occipital lobe, but and an associative region as well. So basically, it's like the primary cortex is where the information is first received, and then the association area is then it's been received, organized, and then interpreted within the associative region. So that happens on both sides of the brain here. And yeah, mostly that's what I want to point out there. So damages to area in the primary motor cortex. So if we look back here, we see the central sulcus, and here's our primary motor cortex. Paralyzes muscles controlled by those areas. So if you look at the vascularization of the brain, let me draw something out if I can do it real quick, is that you have vascularization coming into the brain, and then it's moving around, and it kind of does this kind of mapping as it provides the vascularization to different points. So when you get a point like this, a bend in here, these are these different vascularization points where you can get a ballooning or a pooling or stagnant blood. So what happens is that we can actually, by we, I mean like within the medical community, doctors can distinguish what part of the brain was affected, or because of, you can make an association between what part of the brain was affected based on the like clinical presentation of the patient, right? So you're like, oh, clinical presentation shows a left cerebral hemorrhage, right? Like there's got to be something happening in that spot. And then on top of that, the more specific you can get, you can start to determine what part of the vascularization within the brain had that issue. So if you catch this kind of like symptoms of stroke, or you go into the hospital with a headache and they say that they can tell it's related to your brain, what they'll do is they'll actually go in. I'm looking for my arrow. Hang on. Let's see. I got no, I got nothing. All right. I'll just keep talking and hope my computer works in a moment. So what they can do is they'll say, okay, then what they'll do is some brain mapping, where they'll take photographs of what's going on within the brain, and then they'll determine what part of the arterial supply got the infarct in, or the pre-infarct, right? Because if obviously you would want, if you have just a little bit of a symptom like of a headache, of lack of consciousness, what else would it be, like nausea? There's kind of different things that could come up. Um, but what they can do is just go in and then widen that area and place a metal coil in there, and then it'll allow the blood to flow freely instead of continuing to be an issue. So the intervention here has come a long way, as far as being able to do these type of um, miracle works for the body. I don't know if I'm going to be able to get out of the system here, guys. I'm frozen. Hmm. Mm-hmm. I can't even stop the. Oh, there. Oh, look, we're catching up. Yeah. I'm pressing the escape button. Nothing's receiving. I'm gonna try. See, I got my arrow again, and then it just disappears. Oh, okay. So there. So my mouse disappeared. There we go. Thanks for your patience with that, and we'll move forward. Oh, I gotta erase it. That's right. Yeah. You can read this while I get my eraser out, and then I won't read it to you. That was a bit much. Okay. Yeah. Um, okay. So what happens if we have a stroke? Can we recover from it? And although we can't replace that damaged neural tissue, yeah, there's other neurons that can reprogram, right? Neuroplasticity to take over the skill of the damaged ones. So so I work with, or I should say, I formerly worked with someone from Thailand. She's another physical therapist. And she said, in Thailand, we don't have any issues with someone having a stroke and recovering, because you have to take care of yourself. So in that culture, if you were to have a stroke, you would still have to get yourself to the water source and carry your water back to your home. And that kind of work performance forces a person to use their body and remap and reprogram their brain to then activate their muscle strength again. So what was lost, based on what used to control the motor output, gets put in again in a new way. What happens in our American culture, for the most part, if you get the traditional intervention or traditional care, is that people tend to help you. So they bring you food, they bring you water, they help you with your activities of daily living, right? Which could include toileting, and other things after a cerebral vascular accident. So what that does is it makes the person not have to force their brain to reprogram for those activities. So what we can do is, we can, as a physical therapist, we set up ways to encourage activity of a limb, let's say like of the arm, um, in order to get the reprogramming to happen. So one idea is constraint induced therapy. So say I had a stroke on the left side of my brain, so I lost the right side, my right hand control, my right arm control. So then my physical therapist would come along and tie down my left arm so I couldn't use it for anything. And I'd have to, constraint induced therapy, I would have to use my right hand to eat, right? And so by forcing me to do the activity, or like it could be some other could be something else, like I give a pegboard activity or something like this, and they can't use the left hand, they have to use the right. And by forcing that person to do that movement, again, it will lead to recovery. This is the tailwind. This is a okay, well, okay. This is in the PowerPoint that I posted, and if you play this, it's a very long video. If you watch it at double speed, you can get a lot of cool information. But what I love about this, these two women developed something that uses bimanual coupling. So that's that concept that I can generate a force with my right arm and my left arm. So if I'm working out and I alternate right hand, left hand, I have to generate a lot of power with each bicep repetition. If I do both hands at the same time, the neural output actually it has an easier time commanding the motor control because of the bimanual two-sided contraction, right? More than one. So they use that concept, and then another concept which is also really cool, which has to do with auditory cueing, which is something that we use with patients with Parkinson's disease as well. Auditory cueing is like I'll like clap as the person's walking, so I can clap their cadence and their gait. Or if you use hiking poles, it makes this really nice like clanking noise on the floor, and that will help the brain signal the motor output as well. So these women took those concepts, put it into this device that they designed, and so I'll just show you a quick piece of it in action, maybe like in
recognize that there still is potential to change.
Okay, so that one's not using the bimanual coupling. But here's
introducing Tailwind,
there it is.
a revolutionary new arm rehabilitation device.
Yeah. So that's all that the motion is doing, and the way that program works is basically you get in 5 minutes you get 200 repetitions. So if you follow the cadence of the auditory cueing and you use the bimanual coupling approach at the same time with 200 repetitions, you end up getting good results if it's used daily, and the more times a day. So with rehabilitation, repetition is key. And the same thing you could say with sports, right? If you want to be the best soccer player in the area, just kick that ball. Like do nothing but practice soccer skills. Okay. We talked about it occurs on the opposite side of the body. What's a transient ischemic attack? That's when there is just a temporary blockage of blood flow, so it's not permanent. You could suffer several transient ischemic attacks and not know it. You might have symptoms of a stroke and ignore them, but it's really good if you start like slurring speech or getting lightheaded in the shower. These are typical presentations that happen to folks. Then you would want to go to get checked out. I had a friend from college who I went to visit her. This is I was in grad school, so it was probably 8 or 10 years out of undergrad. And I go and she says, yeah, I was in the shower and I started feeling really weird. And I called out to the dogs something. And when I called out to them, my talking was all jarbled. And she even went as far into when she looked in the mirror, she said that her face looked weird, right? So she had all these symptoms. She goes to work, and she's a social worker, and she tells the nurse at the school what happened, and the nurse is like, oh, that's odd, or whatever. And I know this happened to her more than once, but here's the thing. I'm in grad school, so I'm deep into neurology, and I'm like going through my notes, and I'm like, man, that sounds like something that you should get looked at. So I suggested that she go to the doctor, and she did. And so they did diagnose her with this TIA. And what they did was they changed her birth control regimen. So one side effect of birth control can be stroke. So when they changed that, it took her out of the at risk, and to this day she hasn't suffered another one. But she had two, so she had two occurrences before she got checked out. Okay, so this is I'll play this for you guys. Just click here.
April 2nd at 6:42, and the sensation is happening again. Smile, they said. Smile. It's all tingling on the left side, on the left side. The doctor said to breathe in, breathe out, manage distress. And I'm trying. I don't know why this is happening to me. It happened this morning again. And when I left the hospital Monday night at like 12:30 in the morning. So now I'm taking a picture for an example of what happens. It's 6:43.
Okay, we'll pause there. So, so typical, not the paralysis is happening on one side of the body.
April 2nd is
Okay, phew, get out of there. So here are the signs of stroke: face, arms, speech, and time. So typically you get some sensations in the face. You might notice the inability to move one of the arms. The speech becomes slurred, and then time, fast. Oh, so fast. The time is that the sooner you can get looked at and treated, the better, because they can give you drugs, blood thinning drugs that can help with that, and if they need be to do surgical intervention as well. Okay, so this is just more of the typical presentations: a sudden numbness, weakness in the face, arm, or leg, especially on one side of the body. That makes sense. The confusion, trouble speaking, right? Because this is all happening from an issue in the brain. It could be trouble seeing, it could be trouble walking, imbalance, and then severe headache without a cause. So with my friend, right, she had loss of balance. She had the numbness and weakness in the face, and then the trouble speaking. So she really showed 3 out of these symptoms during her transient ischemic attack. Okay, so yeah, so that's within the brain and the vascularization. So right here you can see a vessel of blood supply going into the brain matter. So to get in there, right, we have the skull, we have the dura mater, which is the most superficial of the meninges. Then we have the arachnoid mater and the pia mater. Together, they form what we call the meninges, which is basically a wrapping around the central nervous system. I just want to say how incredible it is that brain surgery, they cut through the bone. Man, it's just incredible. They can cut through the bone and access the brain and do what they need to do to help people. It's absolutely incredible. Okay, so here's a picture of the dura mater, and that would be the most superficial of the meninges. So we have the bridging vein from the dura to the pia. So from the dura to the pia, there's the vessels in between, and then here we see the pia mater. It doesn't have the arachnoid mater layer illustrated. You can't see that visually here in this picture. But here's that's the thin, most proximal or closest to the central nervous system tissue is the pia mater. It's the one that's the final wrapping of meninges around the brain. This is simply a lateral view, more of that delicate pia mater. You can see the dura mater, which is the superficial, and the thickness of that and the difference. And then the arachnoid mater is again not pictured in between. But we can see that here in an illustration and know that it does exist. So what do I want to tell you about shunting? Well, this is hemorrhage. So, but there's a little shunt coming out to get the blood out. So in a hemorrhage situation, which is different than an ischemic attack, in a hemorrhage you get excess of blood, and so this is associated with like a very bad headache, all of a sudden thunderclap headache, and the more blood that pools within that, so if you have like a vessel that bursts and then there's blood leaking within that, it'll start to pool. And as you can see in the illustration, it places pressure on the brain, on the cerebrum. So when we say a subdural hemorrhage, right, that's a hemorrhage below the dura mater within the meninges. So the way to get that blood out is to use a shunt or a drain, and you can drain that blood out and relieve the tension. So again, you can see how time would really matter. So if you go to the hospital when you have that thunderclap headache, they're going to be able to treat you sooner. You're going to have less neural tissue damage. If you go to sleep that night and wake up hours later with the same issue and then go, you're going to have more severe damage. Okay, that goes without saying. So an epidural hematoma would be between the skull and the dura mater. The effect is the same, okay, except for that here in the previous one, it was like the pia mater that was still the wrapping and pushed into the brain, and here we have the dura mater is also being pushed away from the cranium, right, instead of being attached to the cranium. So you can see here, that's where the blood pooling happens. So right, epidural is around or above the dura, and then subdural would be below. Okay, sweet. So I'll stop my share for now. That was kind of the rock and roll central nervous system introduction. I hope you found some of it interesting. A general overview of the control center and how it works. And we'll go into other parts of the brain in the next lecture, so we get a little bit more in detail. So that's really it. I hope that you enjoyed the material. Yeah, I'm excited because we're in good shape for the rest of the semester as far as finishing on time. There's no hurry. When I first looked at it, I was like, ooh, there's still a lot to cover in 5, but we're good. We're actually we're in a good, safe spot here. So that's all I have to say. If you have any questions, you can let me know. I'm going to stay after if you have something specific to chime in about. Otherwise, this is it for the recording. I'm going to pause it here. And